Dear colleague, the case you are bringing to our attention will give us much to consider. Keep in mind that it will be addressed in three parts. In the first part, I will show how, during the initial examination, there were no signs indicative of cerebral hemorrhage, and the only clue we found was the reduced size of the cavum of the septum pellucidum and two small spots. Several people told us, go ahead and do the MRI scan, and after a period of 24 hours, you will be able to see and understand exactly what happened. The patient had a normal head morphology, and here you can clearly see that both of the trigens are perfectly regular in their overall appearance, and there is no evidence of hydrocephalus or any sign of alteration at all. You'll see that our observation was based on the fact that the cavum of the septum pellucidum, which I've pointed out here, was extremely small, and we weren't sure it even existed. So since the patient was presenting head down, I rightly decided to perform a transvaginal examination. The cerebral study turned out to be completely normal. And I'll show you this again so you can clearly understand that the only sign present was this reduced cavum of the septum pellucidum, which is indicated here. Now you'll also see a normal, here it is, and here it is pointed out that the cavum of the septum pellucidum is extremely small, and so on. Let's keep looking, and we see that the trigens are normal, that there is nothing else. Sign. Prompted by this observation, by this finding, we decide to continue the investigation transvaginally and again transvaginally. Thank you. We observe a normal corpus callosum, which you can see here, and just notice there's a little white dot. Do you see it? At the level of the transition between the rostrum and the genu, at the level of the genu and the body, the corpus callosum was normal in size, but we were struck by this small spot you see, which I keep showing you, which drew our attention. And here you see a normal vermis, here you see a normal corpus callosum, and here at the level of the body, this small spot. Here you see the septal cavity, which is present, and notice carefully that the frontal horns are normal, because later you will see what happens just a few hours later. At a distance, here you see this little spot. Do you see it? I marked them for you because they were something that was probably trivial. But given the fact that there was a smaller cavum septi pellucidi, we reported it. We said, proceed with the MRI. Soon you will hear the MRI report, and then you will see what happens in less than 24 hours. This is the end of the first part of the recording.
The day after the ultrasound was performed, the patient underwent a fetal MRI, of which we are now seeing the first images. These are the sequences in the axial plane. They are single-shot images. The first is a turbospin echo, so with T2 waiting, and the second is a T1. Both are acquired in the axial plane, as you can see from the images scrolling by. The main finding is the presence of a hemorrhage within the left lateral ventricle, which we can also assess in other planes, again using single-shot turbo spin echo sequences in the coronal and sagittal planes. Here we carefully observe the ventricle from several different angles, and we can clearly see that the hemorrhage is mainly located in the frontal horn, in the midline area. What is especially interesting is that with MRI, we are able to not only study the anatomical structures, but also observe them in detail. With great detail, so we can see the hemorrhagic focus highlighted by the blue arrows and the lilac arrow in the first and second images. But another interesting point is that we can determine precisely the time that has passed since the onset of the hemorrhage, essentially determining its age, by studying the degradation products of hemoglobin. So we are faced with, if we look at the table on the right side of the image, we are dealing with a hemorrhage that occurred between 12 and 48 hours ago. Why? Because with the lilac arrow, so in the T1, we observe that the lesion is iso-intense with a hyperintense rim, as you can see here, while in the T2 weighted images, we see a hypointense signal in T2. With the green arrow, we can see that the head of the septum pellucidum is clearly visible, and in this last image, we observe left ventriculomegaly, borderline, with a ventricular diameter of 11 millimeters, within which a fluid level can be seen, hematic. The hyperintense part is fluid, the hypointense part is blood. This is interesting because clearly, in the specific case of the patient under study, it is a finding that we could have deduced even from the anamnesis. The ultrasound had been performed the day before, whereas the MRI was performed the following day. Clearly, in this time frame, it is a finding that has changed, so a focus has developed. However, in the absence of any other data, the study of hemoglobin degradation products allows us to date the hemorrhage with accuracy. Lastly, there are the DWI sequences with the ADC map, which highlight the lesion for us. Here as well, the hemorrhagic focus is highlighted by the yellow and green arrows in the DWI and orange in ADC.
We continue with the same case to verify the progression of the picture that we had initially evaluated, like small spots, endocaranic, endocerebral. There is certainly an asymmetry of the occipital horns of the cerebral trichomes, where it is clearly possible to recognize a slight increase of the horn biometrics proximally, while the frontal horns appear somewhat more noticeably closer together, slightly approaching the midline. And here, in the portion proximal to the probe, a large effusion is evident in the area of the germinal matrix, that is periventricular. What was highlighted was only a small portion, which referred to an area of liquefaction within the context of the hemorrhagic effusion. The examination had started a few days earlier at the scheduled time, with an indication of a small septal cavity, but with a corpus callosum, normal, which is also confirmed in this case. One of the important aspects to promptly check in cerebral homology is the possible presence of fetal anemia. But as you can clearly see, thanks to the assessment of the peak velocity in the middle cerebral artery, there is absolutely none here. Fetal anemia. What we need to note is how, over a relatively short period of time, the encephalic picture, which is the overall appearance of the brain as seen on imaging studies related to an intracranial hemorrhage, which is bleeding within the skull, changes substantially. These changes can occur quickly, sometimes within just a few hours or days, depending on how severe the bleeding is. You can see, once again highlighted, this additional area of liquefaction within the context of the effusion, and how this effusion is actually particularly significant, especially in terms of its clinical relevance. In the area, as we said, proximal to the probe, we continue our thorough examination as we try to thoroughly identify the entire affected portion, and this is the complete and detailed biometric measurement of the effusion. Present in this space, which you can see is about 1.5 centimeters, which obviously in a space during the second trimester certainly represents an important prognostic factor. The other aspect that I specifically wanted to point out is that in reality, as these images slowly scroll by, you have likely seen and noticed how the MRI findings are actually just slightly different. In the MRI, the effusion in the ventricular cavity was clearly highlighted, whereas here, from an ultrasound perspective, the frontal horns appear to be free of any effusion within their cavity. The MRI also revealed a slight but nonetheless noticeable increase in the biometry of the trigon on the same side as the effusion, whereas, as you observed, especially in the initial phases, the biometry was consistently within the normal range, that is approximately 8.3 to 4 millimeters. Once again, we can see that the frontal horns appear, of course, to be closer together. But in this particular case, there is actually no clear or obvious hematoma present in the area highlighted here, which is different from what appears in the MRI. So, to conclude, I would say that fetal intracranial hemorrhage still remains to this day a significant and real enigma for us, especially from a diagnostic point of view. This is due to the fact that the ultrasound findings can fluctuate or change significantly, sometimes even over a relatively short period of time. Another important point I would like to make is that the two methods, ultrasound, whether transabdominal or transvaginal, and magnetic resonance imaging, are actually entirely indeed complementary techniques, especially when dealing with this type of pathology, because there are certainly some elements that may be missed by the ultrasound exam, just as there may be details that are better seen with the ultrasound investigation.